Welcome to the Resilient Butterfly Podcast. My goal is to share inspiring stories of healing and recovery through many diverse approaches and models. Our guests bring incredible lived experiences, insights, and/or professional expertise, each with their own unique path. While we highlight and celebrate these stories, our intention is to inform, inspire, and demonstrate resilience and creativity. This podcast does not endorse any one approach. We believe there is more than one way to heal, and we're here to showcase the resilience and possibilities that exist. Welcome to Resilient Butterfly. I'm Pam Feinberg-Rivkin. I'm so happy to be here today with Dr. Barbara Krantz, who is a family medicine physician and addiction medicine physician, and has such an amazing career and respect from so many people, I know, at least in South Florida, and who knows where else. And I'm here to talk about the resiliency in her life, as well as what she's been able to make from her story and helping others in their addiction and their recovery from both mental health and neural problems, as well as alcohol or drug abuse. So, Dr. Krantz.
Well, thank you.
Welcome. Thank you. I know you, I think I knew you at Hanley Center, but
I was their medical director for
many years.
How
many years were you?
2004 to 2014.
Oh, okay.
I worked there like per diem prior to 2004 with my family practice, and also I did the emergency room. So it was busy.
Wow.
I was young and very energetic.
Well, we talk about that, and I sometimes when I see you, I'm like, how do you do this? Because you've been at Karen now for over 10 years.
10 years, yes.
10 years.
Over 10 years. Plus, because they bought Hanley, they counted the 10 years that I was there, so really 20 years.
Oh, wow. Yeah, that's such a history there of them owning Hanley and then not owning and so forth. But, the amazing part is, and I assume that you started out as family medicine, but you're in recovery yourself.
I am.
And where did that all start?
So when I was a young physician, I had developed migraine headaches. Now, this is like in the early 1980s. So I'm an older physician now.
Uh-huh.
And at that time, they didn't have the medications that we have today. So they gave me Demerol. The neurologist gave me Demerol. There's no family history of substance use disorder that I am aware of in all the generations that I know about of my family. And so it was a surprise to me when I absolutely became dependent on it. And it didn't take too long. It was within a year. And working in the ER at times, then when the neurologist said, we'll go to the ER, they'll give you a shot. And I was in solo practice at that time, maybe had one nurse practitioner. Then I was like, well, I could just order it in my office and that'll save me a trip. And that was the beginning of the end, very, very quickly for me.
Wow. So I want to go back to everyone that had migraines in the 80s. They actually
gave
narcotics.
Pretty much.
And do you know the statistics of those that were having migraines that became addicted?
I don't.
I
don't
mean,
know
that would be
I could look it up, but
amazing.
But I don't.
I didn't even know that. I was an early nurse back in the 80s. I graduated.
So you gave narcotics.
So I gave narcotics I worked on a med surge floor in the ICU. So the med surge floor, a lot of the back
post-op
patients. And that's pretty much, I was going up and down the floor, just giving injections right and left.
Right.
And it was a lot.
And unfortunately, as a physician, you can give yourself your own injection. which is really very sad.
Wow. So it took you down really quickly.
It did. And what's interesting when I look back is that I had no clue what was happening to me. I was married, had a baby. Like, actually, they thought it was had something to do with postpartum, and then they thought I had a brain tumor, and they worked me up for all of that, and all of that was really negative. And so I just, in order to practice, I knew that the Demerol would work. And we don't even use Demerol really today, thank God.
Yeah.
But so it was the beginning of the end, and not the beginning of the end, but I mean, it was very quick in using, probably maybe 8-9 months, a year at the most. I don't think I even made it a year, where my husband didn't know what was going on. Of course, my baby didn't know what was going on. And so I called my mother, and she was Miss Fix-It for sure. And I said, I have a problem. I can't get off this medication. And when I do, I get really sick. And in medical school at that time, they really didn't talk about addiction or the neurobiology of the brain as it relates to addiction or anything else. The stigma was pretty heavy.
Especially a physician.
Oh, a female physician, too. I mean, so.
So was your mom
terrified?
Yeah, I would imagine.
She lived in I'll tell you how terrified she was. She lives in North Miami and made it to my house in Palm Beach Gardens probably in 25 minutes.
Wow.
Picked me up, said pack a bag, and brought me back to South Miami because she had already arranged a consult with an addiction medicine physician in that period of time. Very
amazing
efficient.
Mother. Wow.
She was an amazing mother. Totally.
Wow, I'm going to cry. That's really amazing. And was she a physician herself?
Nope. She
just was very...
her and my father owned stores, chain of stores in New Jersey.
But she was very resourceful.
Florida. Always very resourceful.
Wow. Did you have siblings?
No, I was the only child. Oh. So I'm totally spoiled. I don't share. I've been told that. She doesn't share. So, which I don't think is true, by the way.
But you had I'm sure it is not true, but you had a mother who came to your side immediately, helped you out. And were you in Miami? There isn't a lot of treatment now. Back then, there was some.
South Miami Hospital. Dr. Dolores Morgan. She's deceased now, but she was like a drill sergeant. And again, being really naive, not understanding anything about addiction, she asked me all these questions. How much are you using? How are you using it? When did you start? I mean, appropriate questions. You would take a regular medical history. But I told her everything. Little did I know that she worked for the Board of Medicine and was part of, at that time, it was called Impaired Physicians Program, which is really a bad name. Sure. I mean, Professional Resource Network today is much better.
Right.
I mean, it again shows the stigma and the understanding that we had of substance use disorders back then.
Of course. And what did you have to do for your license at the time?
That became interesting. So like I said, I told her everything, especially about giving myself injections, ordering my own supply to the office. I mean, they delivered it. I mean, and I did have patients that we had to medicate at times. But so she had all that information, and I was like, okay. And she's like, well, you're going to stay here. We're going to detox you. Again, I really didn't know anything about detox. So I'm like, okay, well, that worked for about 4 days. Our detox today is much more comfortable, I'll say, than what they really were doing back then.
They were just watching you suffer?
Pretty much. I remember saying to her, well, I haven't slept in 3 or 4 days. And she's like, well, you won't die from not sleeping, really. I mean, she was hardcore. She was excellent physician. Right. But she was like, You're not going to pull anything with her.
You can become psychotic from not sleeping.
Right.
Which we talked about in one of the other podcasts.
I actually think, and I probably shouldn't say this on the air, but I actually think I said to her when she said, it was probably another couple of days, I said, when you told me that I'm not going to die from not sleeping, you might. Honestly said that to her. I mean, that's the mindset that you're in when you're going through withdrawal.
Because you're suffering.
You're suffering. You're not in your right mind. Most people, including physicians, maybe not so much today, but don't understand what's going on. I mean, I had no experience. There was nobody in my family that had any kind of substance use disorder. I didn't know anybody that had any substance use disorder. I did meet a lot of people then that I didn't even know had, because it wasn't really talked about at all. Right. So it was an interesting time.
So you went through detox, and then did you do outpatient treatment at that point? Or?
So in her wisdom, she told me that I should go to Georgia. Dr. Talbot is a well-known, very known in the field. As a cardiologist, he himself was in recovery and also now deceased. And
it became the go-to for physicians.
Right. So Georgia, Ridgeview, she recommended I go. And I'm like, okay, but I need to go home. So they let me go home. So I didn't go. And 2 days later, Roger Getz, who is the head of the Impaired Physicians Program, called me at home. And he's like, Barbara, aren't you supposed to be in Georgia? I'm like, I know. I think she means well, and it's probably a good idea, but I'm good. How many times have we heard that?
Right.
I'm good.
Many.
I'm good. So he's like, well, let me make it clearer for you. I remember this so clearly myself, is that he's like, well, the next person that calls or comes to your doorway will probably be the DEA. I said, well, why? He's like, well, it is a felony to prescribe medication for yourself to your office for office use. I'm like, I mean, that never even crossed my mind.
Right.
I mean, in the throes of addiction,
you don't think about those things.
You really are not. You're thinking more of that. Let me get through the day. So I went to Georgia the next day.
And how old was your baby?
6 months.
Wow.
6 months old. So my mom came and helped my husband with the baby.
Wow. So then after treatment, is that when you decided to become addiction medicine physician, or was that down the road further?
So after treatment, it gave me a better understanding. I still didn't want to talk about it. And walking back in the hospital, where there weren't too many female physicians back then, actually, in Palm Beach County.
Where did you go to medical school?
In Iowa. And then Jackson Memorial in Miami, did my residency.
Got it.
So there weren't many
physicians,
female physicians. So I was, embarrassed. I remember the shame and guilt that I felt, even if I didn't express it a lot. I still didn't understand what was wrong with me. I didn't understand why I was acting irrationally and irresponsibly when I didn't believe that was my nature. And it really wasn't my nature.
I'm sure it wasn't. I mean, getting addicted to Demerol because you have migraines is not something that you planned.
No, not at all. And I think when you asked me how long did it take for me to get into addiction medicine, probably another, I'm trying to think when I took my boards, probably another 5 years, because I wanted that part of my life behind me.
Sure.
And again, without really education, even in med school or residency, about the disease, I was, again, embarrassed, didn't want to talk about it, thought it was a black spot on my record.
Right.
And it can be if the DEA had come.
Sure.
I mean, so.
What did, in regard to your license, did you have to go through certain aspects of treatment or check-in, or what was that back in the 80s?
So that was interesting too. And it is, it's so much better today as far as, because again, it's the education and understanding about the disease.
Sure.
I was, again, in the impaired physicians program. So they kept me, Dr. Talbot kept me a little longer than the other docs because I wouldn't say that I was an addict. I'm like, that doesn't define me.
So he kept you there until you admitted to being an addict?
Well, I didn't quite get to that point, but yes, in the circle, I did say it because it dawned on me I'll never get out of here.
Right.
I mean, it
Wow.
was very real.
That was interesting. That doesn't happen today.
No. No. But I mean, and it wasn't even denial. It was like, help me understand what's going on with me, that I am acting this way. I remember the first time I saw Dr. Talbot, I said to him, I need a psychiatric evaluation. And he's like, when you say that to a doctor, it's like, oh my God, what's going on here? So he looked at me, he goes, well, that's part of the program. You'll be evaluated. So I'm like, well, good. So I had my psych eval and the psychiatrist said to me, you're fine, Barbara. I'm like, no, there's something wrong. Can't you give me a pill to fix it? I mean, that was my thinking.
Right.
And again, you're just at a medical school and residency and you medicate everything.
Well, that's what a lot of physicians still think, that they can give a pill to somebody because they can take care of whatever's going on.
Exactly. Pharmageddon is alive and well.
Pharmageddon.
It is. Well, I did a lecture on that one day before in the past. But it is. I mean, and it's sad because they're better now, I know, in medical school, where they're teaching about the neurobiology of the disease, and again, the primary symptom being that compulsivity, that irrational, irresponsible, returning to the drug despite all these adverse consequences.
Right.
Like potentially losing your marriage, losing your custody,
everything.
It doesn't really dawn on you. It doesn't sink in, maybe I should say. So I have a lot of empathy for patients because I've been there and done that and was so confused and thought I was educated and intelligent. And it didn't seem that was true.
So did you want to become an addiction medicine doctor to use your experience to help others, or is that just one of the reasons?
I think that's certainly one of the reasons. I mean, I'm in addiction medicine because at first, like I told you, I didn't want anybody to know anything. My past was my past. That's it. Let's sweep it under the carpet. I'm not proud of it. Still had a lot of unresolved issues relating to it. And again, the education and the understanding of the disease of addiction back then wasn't there. Sure. I mean, it was really late 1990s, early 2000s that with technology and breaking the genetic code and everything else that we learned so much more about it. So I did go into addiction medicine. I want to say probably, I should know these dates, but I'm old, so I have an excuse.
Just a rough estimate.
Probably 1990, maybe in that range. So I've been in the field a while and seen it go through many different names. It was called AMSOD initially.
Really?
Yes.
I didn't even know that.
Yes.
What came? What
I was hoping you wouldn't ask me what an acronym
I don't understand
was for.
how that.
It was
AMSOD?
AMSOD, American Society of Alcohol and Other Drug Dependencies, or something to that effect.
Huh.
And then American Society for Addiction Medicine. And I mean, well, that's what it is now, an ABAM, and American Board of Addiction Medicine. But that's a board.
You had to go through a residency of addiction medicine.
No,
at the time,
I didn't. At that time, I just needed to be able to pass the boards.
Got it.
So maybe they thought personal experience helped. I don't know. But I did take the boards. I was still in family practice. It's amazing when I look back is when all of a sudden it seems like coming into a family practice or even in the emergency room, because I worked level 1 trauma at times, that we had all these addicts, quote addicts, substance use,
Right.
dependent patients that I never even recognized before.
And then when they came in after you had that
My own
experience,
personal
then
experience,
you could recognize.
I was able to recognize it and therefore give more compassionate care
Sure.
because some of them are not nice when they come into the
You know,
ER.
that I so much believe that in some regard, people in this field of addiction medicine
Mhm.
or therapist or an interventionist or anyone has to have their own personal experience, not necessarily in a substance use disorder or
Right.
alcoholic disorder,
Right.
but having that experience in the family, some knowledge behind it, because that those that don't seem to have that same connection to what the patients need.
And are walking through,
Right.
you know, I mean, I know even in the emergency room prior to that, if I had 2 patients, and one was going into alcohol withdrawal and the other one had, you know, trouble breathing, but not like putting on a vent kind of trouble breathing, I would attend to that person. I mean, I hate to even say this.
Sure.
That was before I went into treatment, as opposed to the other. And probably innately, I had an understanding they didn't know really what to do or how to help. And maybe that's it. People don't know how to help.
Yeah.
Um,
Yeah, it was interesting. Not a few weeks back, I saw a man that was clearly inebriated, laying on the ground outside of Publix in the middle of the day.
oh wow.
Older gentleman that his clothes were not like he was a street guy. And I called 911 and then I told the manager, he says, I already did that, and walks into Publix. And the emergency people come and they just watch him. They're just watching him on the ground. And I'm like, there's just this disconnect there.
There is a disconnect, and it's sad because that misunderstanding of this disease, I'm sure, has been my passion for the past 20 some odd years.
Sure.
Really understanding it, treating it more appropriately with the knowledge that we have today.
Yeah. Well, it sure shows when I work with you because you have such passion for and such a connection to patients and their needs. And you've worked with creating a neurocognitive program at Karen. Tell us of the audience a little bit more about that.
I would love to tell you about that, Karen. So I have been doing parts of this program even when I was at Hanley, before I was the medical director at Karen. And the bottom line is, as a physician, we are trained to treat the organ of the disease, if we can identify that, or at least look for it. So the organ for the disease of substance use disorder and mental health is the brain. It's as simple as that, but as complicated as that.
Sure.
So I have been imaging the brain through different technologies, mostly perfusion studies to see blood flow, to see if you didn't get blood flow to your hand or your foot, you wouldn't be able to walk or shake hands or, it wouldn't function.
Right.
And it's that simple, but more complicated at the same time. So again, looking at the target organ for the disease, as most physicians are trained in looking at, that it makes a difference in helping the patient understand that they have a disease.
Yeah.
Because it's not a moral failing.
Right.
I mean, do we make really bad decisions at times? maybe even crazy decisions.
Well, when you think about it, someone with a brain tumor makes bad decisions as well.
Right.
Someone with a traumatic brain injury
Right.
that's not drinking or doing drugs makes
Right.
bad decisions. So
Right.
it's the same way that we could look at it for everybody.
And we at least, we know much more with technology today and genetics and all the behavioral. We've been able to treat the behavioral aspects in the sense of, identifying what skill sets you're going to need to maintain some kind of structured social support system when you walk out of treatment. But I think at times, most of the patients that I've seen, even to today, will come in and especially alcohol, because it's widespread.
Right.
And, their mother drank and their grandmother drank. And,
history.
I mean, it's a normal upbringing. It's not abnormal until they start falling or going into DTs or things like that. So understanding what's going on that's helping you make those bad decisions is really important, as with any disease. So at Karen, we have a team approach. We have a really good team, if I say so myself.
I heard somebody recently came on board there as the director of clinical services for Ocean Drive, I believe.
Yes, Maddie.
Maddie.
Yes, Maddie.
Yeah, she's a lovely, lovely woman.
She is. I worked with her before.
Very professional, enthusiastic beyond.
We've got a lot of enthusiastic
That's great.
people that I do believe really love patients. But with our team for the neurocognitive assessment program, which is called NAP, and I'm not sure that's the best acronym to use, quite honestly. But
as if they're taking naps.
I know, really. Just lay down and you'll be fine. No. We do obviously the medical, the complete history and physical. We do concierge lab work where we're looking at other things that we know substance use can affect, whether it's inflammatory markers, metabolic markers. We're very inclusive of all of that, even, hepatitis A, B, and C, things, so we do a very concierge blood profile. We also do something called Genomind, which is the genetic testing. So a patient may come in and they've been on medications and they're not sure if it's working for them or not. I have found, even in the ER, this being very successful, post-ER in a family practice, where we can do the swab for the patient and get the results back, and it'll tell them their genetic metabolic pathway for breaking down medications. So what medication's going to work for you, what's not. It's not.
That should be done for everybody.
I agree.
Rather than taking pills for nothing, right?
Right. I agree. And it's not just even psychiatry. I'm not a psychiatrist.
Right.
But I mean, statins, blood pressure medicine, everything is on the list. And you could Google 10 years from now, drug XYZ metabolic pathway, and it'll tell you what the pathway is, and you'll know if you can take it. So I think it's a good test.
Absolutely.
And then we look at the brain. So we know a lot about the neurobiology of addiction, much more than when I was in treatment.
Sure.
So we know the reward pathway. We know the dopamine release, then the restriction, and why people continue to do the drug to stop the craving. And I mean, I could give a whole lecture on that. But the bottom line is we have a much better understanding of that. But if you don't look at the brain and perfusion, blood flow, then how do you know what's working in the brain or not? So I happen to do FDG PETs, which is a perfusion study. You could do SPECT scans or other perfusion studies. I'm hoping that we're going to have a functional MRI unit that we can work together with someone. Yeah. We had a meeting today. I can't say anything, but I mean, that would be awesome. So we do that. So instead of just the normal treatment, ours is I think I'm prejudiced, but a lot more sophisticated, but we're actually treating and targeting the organ of disease.
Sure.
So we have a great neuropsychology department and a neuropsychologist that works with us. And they will do a deep dive with cognitive proficiency. Like the older woman that's been drinking and then, it's not out of the ordinary. Maybe she's not even getting drunk at this point in time, but how does that affect her,
Right.
Even in decision making? So we understand, prefrontal cortex. Usually with alcohol, we see blood decreases to frontal and temporal areas. So mood, memory, executive functioning, forward thinking, impulse control, personality. So we can identify what areas of the brain are not functioning and what treatment modalities that we'll use for it. We also so the brain's not just perfusion, it's electrical. So we do a QEEG. We have a special machine that does a deeper dive and actually will look at connections in the brain. So when the brain is trying to get the drug, those connections can change, but they may not be in your best interest by any means. So neurofeedback can be appropriate. We do a lot of neuromodulation techniques.
So is there a particular age group that you're doing this mainly on, or is it, how do you decide? Because that's a lot of testing over a period of time.
So we have a specific NAP program that's 10 to 14 days, and that is 10 to 14 days if they don't need detox, because we can't do it under the influence of drugs. It will, skew the results. And it is intensive. I mean, they're doing a lot of testing, but we can So
they come in and they do the 10 to 14 days of testing and then determine what the treatment would look like based on all of the results of the testing.
Ours is an assessment program, and then we make recommendations.
Got it.
Do you have a substance use disorder? Do you have a mental health disorder? Do you have both?
So are you doing it on the mental health patients without the substance use disorder?
We have done it on persistent depression.
That's interesting.
Because we have other neuromodulation techniques, including TMS at Karen.
When did you start the TMS at Karen?
I don't want to give you the wrong answer. I know we've had the machine at least a year. I would say maybe 6 months, 3 months. Okay. I'm not trained on that.
Can you describe the TMS to the audience?
It's magnetic. It's transcranial magnetic. So it's trying to change the brain waves in that area. Probably can't explain it very well because I don't do it. We have a psychiatrist that does it.
It's mainly, to my understanding, it's mainly done for compulsion and depression.
It's dorsolateral prefrontal cortex that they're usually looking at. So major depressive disorder, persistent depression, impulse control, yes, would be involved in that. And I think it's like 30 treatments that you actually have.
Yeah.
So
it's a long process.
Right.
Well, not so long in the lifetime of somebody, actually. When you think about it, it's not a lifelong. When you think about any treatment that jumpstarts your life to another level of how you can function and have an amazing life in the future, it's a very short period of time that people can't understand going through the beginning of it. They want a quick fix, like anything. It's like you went home.
I know.
And the biggest thing with detox for any of us that know treatment, it's like you don't want to send somebody home after detox.
Not a good idea.
Because you're not going to see this person again.
No,
until they're drinking again.
Right. And then the progression, you don't know what's going to happen.
Yeah.
I think one of the we've seen a lot of interesting cases. We see a lot of complicated cases in the NAP program, but also, and I hopefully I can say this, it's a plug for Karen, because it is a nonprofit. I mean, we had a young girl, 28, 27 years old, that came from Georgia, that had been in the hospital on a ventilator for respiratory arrest from fentanyl and heroin, essentially, and was being raised by her 80-year-old grandmother.
Wow.
Her father was deceased from substance use. The mother was not totally in the picture. And she came to us, and after the grandmother, so she actually got off the vent, lived, which is amazing. Her youth helped, I'm sure. And then went home, was discharged, and 5 days later, her grandmother found her on the bathroom floor, not unconscious. So the grandmother knew enough. She called 911. They Narcaned her. She didn't need to be ventilated. So that was a good thing. And then they sent her to a rehab psych kind of facility. And then actually Karen got her after that for placement. So when I saw her, they said, so the notes coming in, cognitively intact, ambulatory. Well, none of that was true.
Oh, wow.
So she had an ataxic gait where she was off balance.
So essentially she had a brain injury.
She really had a brain injury. And it was obvious. I walked in the room and bless her heart, she's putting, how as a little girl you put red lipstick on, you take your mom's lipstick and stuff like that. She's putting red lipstick all over the bottom of her face. I'm like, the problem with cognition here.
Sure.
So we asked Karen if we could scholarship her and do a scan. Her scan was one of the worst I have seen, but why I even bring this up is how many opiate overdoses and how many adolescents and young, well, not even just young people, but I mean, the opioid epidemic we've certainly had in this country. So when you take a narcotic like I did, you get at least some hypoxia because it causes respiratory depression. You know that as a nurse. And then obviously she had anoxia where she arrested and was ventilated and then did it again. So her scan, not one part of her brain was perfused.
Wow.
So we can put these patients in treatment, give them as much skill set as we can, but how much if their frontal lobe for sure,
how do you
executive
create
functioning,
more perfusion when there's no perfusion?
Executive functioning, forward thinking, impulse control, medial prefrontal. If that's not working, how do we really expect them to stay abstinent, let alone get into recovery? So we went back to Karen and execs and asked if I could put her in hyperbaric. And I did. And she got 20 treatments in hyperbaric. And hyperbaric oxygen, I know that from the emergency room because we used it for the bends, the divers coming in. We used it for necrosis. We used it for wound care. We used it for many different things. So I was familiar and I was grateful I was familiar with that. So, and I had been using hyperbaric in the past with patients.
Well, one of my clients had hyperbaric oxygen as a result of your recommendation and something else that was going on medically. So it was actually covered under his insurance and he did improve. So I do know that there is.
It really does work. It's not a pharmacia, it's not a pharmaceutical, but it does work. And then our administration let us repeat the scan because it's medicine, in my opinion, medicine needs to be as exact as it can be. So we can say, you look better, you look like you're doing better, you're smiling more, your affect is better. But is it?
Yeah.
So let us.
That's
subjective, right? So all our data is objective data, standard deviations away from normal, everything we do in the NAP program. So we redid her scan and the neuroradiologist calls me, and I won't tell you exactly what he said on here, but it was like, what what did you do?
Wow.
And she had totally normal perfusion to everything in her brain.
Wow.
I wish I had the pictures here. I would show you that. It's a research study we're going to publisher probably.
That's amazing.
And she was a different lady.
Yeah.
And she's alive and well today. But how many people out there, see, that's what bothers me about this disease, because it's not really looked at as a disease, but more of a moral failure.
Yeah.
And there's so much hope if treated appropriately.
Yeah.
And getting significantly better,
Right.
that it's like, we need to do something more.
And I do believe, though, that unfortunately there are treatment providers for the hyperbaric oxygen treatment that is so costly that it becomes prohibitive for some people.
Right.
When they look at the cost of it.
Right.
So if it can be at a normal price that people can receive this, so it's not prohibitive for so many people.
Right. I mean, I think we get a pretty good price, but I've heard ridiculous prices.
Yeah.
Like, I think a gentleman in New York told me how much it was per session. I'm like,
yeah, in Michigan, it was very
$3,000. I mean, something totally off the wall. But it definitely works. And
now,
again,
I know
how many people out there that continue using the drugs? How many parents are suffering with their children because they put them in treatment, they come out, they look better, they feel better, and then they go back to their substance because their brain is not functioning properly yet.
Right.
It's not perfused. And I know I'm not trying to oversimplify it, but it's part of the problem.
Sure.
So are we doing these people a service?
So I want to say that I'm sure that the hyperbaric treatment centers are not getting from Medicare that kind of thing for the perfusion that they do for a diabetic for a wound, which is covered. The only thing that's covered under insurance is for a wound.
Right.
So why can't we go back? I mean, if they're not getting that much and they're still surviving as hyperbaric treatment centers, why can't they open up that cost for the public?
I agree with you. Totally agree with you.
It seems a non-brainer to me.
No, really. I mean,
that's unfortunately what's wrong with our medical community anywhere in the United States, that it's cost prohibitive in some respects for people. But this has really been very interesting, educating, and I love having you on. I appreciate you coming, and thank you for sharing your story.
You're welcome.
I'm sure that it is going to be a benefit for so many people to hear.
Thank you. Thank you for not telling me what you were going to ask me today. But no, there's hope and healing, and people need to hear that. This is a disease. It's not moral failure and everything else it's been labeled.
Matter of fact, I have to say, and I'll say it again, I said it when we talked about intervention, it has to come from love.
Right.
And if you think of a moral failure, you're angry, you're frustrated, you're all of those emotions that are negative versus and fear, which all come from fear. But if we can come from love, it will allow the person to start to love themselves.
Right. And that compassion that we should have for people that are affected by this disease.
Absolutely. Thank you.
Pam.
Thank you for joining the conversation today. If you are seeking help for yourself or a loved one, please reach out to our Feinberg Consulting team at 248-538-5425. That's 248-538-5425. And check out our website at feinbergcare.com. I'm grateful for our guests and all who have joined us today. Make sure you follow us on Apple, Spotify, or anywhere you listen to podcasts.